Hello, down here. Welcome to Podiatry Practice Mastery, where we're helping you get your practice to the $1 million mark, actually $2 million mark and beyond. So we're already at the $1 million mark. So we're trying to get you to the 2 million, and so that's why I try to give you the information. So I want to answer a few questions. I got a few questions from some doctors. The first one's from Sarah. Her question was, how do you use medical assistants? She always hears me talking about my scribe and then my nail tech, but she never hears me talking about my medical assistant. So I have some great medical assistants. We tend to staff usually at 1.5 medical assistants per doctor. So it's usually a little bit more than one. So usually it's 1-to-1, but there's another one kind of sitting around doing other things, or is available at least to help us when we need it. They might not be there the whole time. The medical assistants, they bring the patients back, they do all the intake, they get all the x-rays before we see them, and they also dispense all of the foam rolling exercises, night splint, morning stretch, DME, collagen, all these other things they're going to be dispensing to the patient, and then the patient checks out. So I just want to let you know how I use them. I use it, usually the ratio is 1.5. Once again, this is a busy practice, so we're all seeing usually 24 to around 24 patients, some days more. Days that we have a nail tech with us, she's kind of bringing in and out her own patients as well. The way I use my scribe, I have a virtual scribe. I do not have an in-person scribe, so Murali is in India, and he's been with me for a number of years. Our rooms are a little small to do an actual person scribe, but I know a lot of practice that have the medical assistant be a scribe, so they scribe and then they kind of go out and they do the DME, or they get stuff that they need. What we tend to do is we have these little call buttons in the treatment rooms, these little, I don't know, like buzzers, and it's hidden so the patients can't see it, but if I want to trigger my staff to come and get me or come and help me, I do that if I need to be rescued, for example. If I'm running behind, I do it if I need, let's say if I need an ankle brace, or if I need a cam boot, or if I need to prep for a matrixectomy or get consent for a biopsy. So they do all that stuff, and so I just tell them verbally, and then they come in and do it because I use this little call button, and that rings out and back where they can hear about it. There is a couple of other ways. I've heard of one practice, they have like something on their computer screen where they have to type it in there if they're working on the computer. I don't tend to work on the computer that much, but they do that. Okay. They also asked about who does like the dressing. So I do the wound dressings, I apply the cantharidin, I apply the salicylic acid, I take out sutures, so I do most of those things. They usually don't take me that long, but I do most of those. My nail tech does help me now with nails, and she does the calluses as well. Usually I'm having to do a little bit more from the callus because she doesn't tend to go as deep. But those are kind of the ideas for the medical assistants. There's also another question about PADnet. I used to talk more about PADnet. I'll tell you what really happened. We've had PADnet for years, and if you listen to some of the earlier podcasts, everyone that's 70 years or older gets a yearly PADnet, 70 years of age or older, and then everyone that's 50 or over with diabetes gets PADnet. The issue was twofold. One, it took a lot of staff time, and now as we're getting busy, so we have 2 doctors and 6 treatment rooms. And the problem is there's not many downtimes when like a doctor is in surgery, and that they used to use that downtime to have the patients be seen for that. Meaning patients would, days we were in surgery, they would be doing the PADnets. But we don't have a lot of that downtime. The second thing, and even the bigger problem, was we switched medical records. And so the one that reminded me of the PADnets was Murali, my scribe, and he's been just kind of out straight. And now that I have Marjorie seeing patients, like, we're just out straight with patients, and there's not a great recall program that I know about anyway in ModMed to like say, hey Don, these meet these criteria, these ones haven't done PADnet, we should schedule them for the patients. Because usually I'm reminding them when I'm in person. It's a little bit harder to do that kind of virtual, meaning calling them on the phone, just reminding them we need to make that appointment. And then plus it would like glut one staff. And sometimes the juice really wasn't worth the squeeze. I think it reimburses maybe, I don't know, 100, 80, 90, 100, which is good because the staff does it. But it takes them, the machine that we have takes them about a half hour, so they can do 2 per hour. I know there's some of these newer ones they tout that they can do a lot quicker, which might be a better way, but that's just kind of where we're at right now, okay? And I guess the third thing is with PADnets, it didn't really change my referrals. Like the real like diabetic limb salvage ones, I'm already sending over to my vascular colleagues, and you don't need a PADnet for that. They have like a blue toe. And so it wasn't really changing. It was more like a monitoring type of technique. And then the other doctor said, I don't have an ultrasound, I have a C-arm to do the injections. And just my words to that, like I use ultrasounds every single day because I think ultrasounds are great for soft tissue. And more importantly, I think an ultrasound could just pay itself in the amount of more shockwave that you can do. Because if you are using ultrasound, you can show the thickness of the fascia. For example, I had a patient today. He was seen, like initially he got new orthotics because like 10 years ago he got orthotics, made his heel pain go away, got new orthotics. They didn't help. He did cortisone injections, didn't help. Came back, did ultrasound, showed the thickness, and I said, hey, we just need to do shockwave. And so he's going to do bilateral shockwave, which is a good reimbursement for us in the office for that bilateral shockwave. I probably couldn't have done it as convincingly without the shockwave. So I find that without the ultrasound, because the ultrasound I can show the thickness and what a normal foot looks like, what the thickened fascia, and the explanation that I've been using lately for that is it's kind of like if you have a rubber band on the bottom of your foot, and if you go from one rubber band to 3 rubber bands, and the 3 rubber bands they just pull more, and they're not as flexible. And then I kind of explain about how if you push up on a rubber band, it can't stretch as much, and that's what the orthotic does. It pushes up on that rubber band. Okay, so those are some of those questions. A couple of other websites I'm looking at. One's called Whisper Flow, and this is something great if you want to, instead of typing, you can dictate. It's like a dictation website. I think a lot of other things can automatically do that, but that might be something that you would like to consider. And then another one had a question for me, the difference between Softwave and Storts, and I think I may have answered this before, but we have one Softwave and 2 radial Shockwave Storts, and then 1 focus Shockwave Stort. So they all kind of work interchangeably, I think, and we call them basically radial and non-radial. But I like having the combination. If I could only afford one, I would probably get a Softwave. If I wanted to get 2, I would get a radial and focused Storts device, because I think that combination works really well in my hands. And I think the focused Storts works really well for smaller areas because the head is smaller and it has better bone penetration. Softwave has bone penetration as well, but I think the Storts does. So those are kind of the devices. There's a lot of other devices. I think you have to get comfortable, more importantly, with doing it, but then really patient expectations. I think that's a really big challenge, and that's something I struggled with in the beginning, was kind of talking them off the ledge. We've done 6 sessions, you've spent $1,500, this is going to be okay. I'm going to see you back in 6 weeks. These are expectations. Okay. And like I said, most of mine are still cash. I'm not doing the insurance thing yet. I don't feel comfortable with that. Okay, so if you guys found this beneficial, let me know. A doctor said, hey doc, I don't want coaching by you, but I just want to set up a call. And like that's what I have. Like on podiatrypracticemastery.com, you can set up like a strategy call with me and just look and you get like a half hour of my time. I'm happy to answer any questions. You can certainly do it via email. Shoot me an email. That actually gives me more ideas for doing these podcasts. But please let me know if you want help. I'd love to meet with you. Like there's a limited time, of course. It's usually during my lunch hour. But I'd be happy to meet, answer any questions you have, look at anything. Some people, they send me their treatment sheets that they're modifying. Like Jackson, and from Australia, he took my good, better, best treatment sheet and he kind of modified it for himself. That's great to see those, so I'd love to see you send those to me, then I can kind of give you some feedback on it. But I'm really happy that people are using these. I hope this is beneficial for you. Okay, have a great one.